Good afternoon, everyone. Thanks for joining us today. We are going to wait a minute or two just to allow everybody that registered to get onto the call. So just give us a couple minutes and we will start. All right, it looks like the joinees are starting to slow down a little bit. So we want to respect everybody's time and get this ball rolling. So again, welcome to Optimum Re's webinar on the fundamental challenges of prostate cancer. First, antitrust statement. Just to make everybody aware, the information presented in this webinar is intended to advance the knowledge and risk assessment skills of the participants. Under no circumstances shall this meeting be used as a platform for the pricing of specific products, determining how they're marketed, or for any other anti-competitive purposes. This meeting does not intend to recommend underwriting procedures or practices to anyone. A couple other housekeeping notes. For questions throughout the webinar, please use the Q&A chat option. It's down at the bottom of your screen. You can type questions there. Dr. J will do his best to answer all the questions at the end of the presentation, but those not answered during the webinar can be emailed to info.us@optimumre.com. That's info.us@optimumre.com. At the end of the webinar, a short survey will be emailed to you, and we really and truly appreciate your feedback. It helps us all improve and get you the information that you need. Speaking about things that are coming up, we are going to be attending AHU very shortly, and hopefully we'll be seeing a good number of you while we're there. So without further ado, I am pleased to introduce Dr. Minas Joannides, or Dr. J, as we like to call him. He has extensive experience in pulmonary medicine and in the insurance industry. I'm sure you have benefited from more than one of his presentations in your career. And we have the honor of having him as a Chief Medical Director for Optimum Re. Dr. J, the floor is all yours.
Oh, well, thanks very much, Lisa. So if I can get everything rolling here. So today what we're going to do is talk about prostate cancer. And we just updated our Optimum Re manual on how to handle prostate cancer. And we had some good help from Dr. Steve Rigotti, who's kind of the dean of working on mortality ratings for different kinds of cancer. So he gave us a hand, and we've updated our prostate cancer ratings. And I have some additional information that I'm going to share in addition to what's in the manual. So I thought I'd combine the manual update and a little extra info for you today. So today what we're going to do, can't give a talk today without talking about critical thinking, right? So critical thinking of prostate cancer underwriting, and we're going to give the snow globe a good shake today and see what falls out, okay? So prostate, I'm getting something across my screen. Hold on a sec. So prostate cancer is the most common cancer in men, age greater than 50 in North America. And you can see in the US and Canada, there's a lot of deaths still due to prostate cancer, even though we screen for it in men. And I'm going to talk about why that still is happening today. And as you get older, men are more likely to get prostate cancer. So a lot of times prostate cancer is found at autopsy, even though the person may not have had any particular effect from that during their lifetime. So it's a pretty common event. And here's what I wanted to bring up today. There's a group called the U.S. Preventative Services Task Force, and they recommend screening tests for different diseases. And they have recommended the following prostate cancer screening guidelines. So here's what they recommend. And you tell me if you trust these people. So for men aged 55 to 69, the decision to undergo periodic PSA testing should be an individual one. So before deciding to be screened, men should have the opportunity to discuss the benefits and harms of screening with their doctor. So basically, they're kind of not really recommending prostate cancer screening, especially if the individual prefers not to get screened. So they gave it a C rating, which is kind of low on the schedule. So not really enthusiastic about prostate cancer screening with PSA. And for men age 70 and older, they gave it a D. So they recommend against PSA-based screening for prostate cancer. So, you know, these are people that are in the business of recommending screening tests. I completely disagree with them, but, you know, this is what they're putting out there regarding prostate cancer screening. So we do a lot of PSA testing, which is good. And, you know, back when I started in medicine, 4 used to be the gold standard. So if you were below 4, no matter what your age, that was good. And if you were above 4, that was bad. So we don't use that anymore. So that's why I put a red line through that. So we measure PSA testing, PSA, and actually the units that are used are very tiny. So it's measured in nanograms per milliliter. And a nanogram is 1/1000th of a gram, which is pretty tiny, right? So we have, instead of having normal, we have kind of like normal ranges for different age groups, as you're probably aware. So for younger ages, you know, even a small elevation can be a cause for concern. One thing you should know about PSA testing, because we're measuring in nanograms per milliliter, it's a kind of a plus or minus 10%. So let's say you did get a 4 as the PSA level. It's probably somewhere between 3.6 and 4.4. So it's really, you got a 10% plus or minus on whatever number you actually used. And it's just because we're measuring in such a tiny amounts as nanograms. I wanted to mention BRCA and prostate cancer. Men who happen to have BRCA1 or BRCA2 mutations have a higher risk of developing prostate cancer. And it's just something to be aware of if you see that in family histories in the US. In Canada, of course, we can't use genetic information, but something to be aware of. And one other key point is the bottom bullet that I've highlighted in red for you. So even if the case looked otherwise favorable, like a Gleason 6, if someone happens to be BRCA1 or BRCA2 positive, they should not be treated with active surveillance. So you probably need a more aggressive treatment under those circumstances. So BRCA could be important in men. Another key ingredient when you're looking at cases is family history of prostate cancer. You know, men with a first-degree relative, father, son, or brother, is twice as likely to develop prostate cancer. The risk increases with the number of affected relatives. So it's 5 times greater for men with 2 relatives and 11 times greater for men with 3 relatives. So if you have a family history that's pretty dense like these, you probably would recommend PSA screening in the kids of those people at an earlier age. And so you may start between 40 and 54 if you had one first-degree relative who has had prostate cancer. So you just want to keep a close eye on that. And this is just some personal information I'll share, family history. I had a brother-in-law, I was at their Christmas party, and he was 56 years old and had a PSA of 3.9. So his doctor said, well, it's below 4, so don't worry, no problem. And he just happened to show me his lab tests. You know, that happens when you're a doctor and you go to a party or something. People want to show you their lab tests or EKGs or things like that. So he just asked me my, casual opinion. And I said, well, at 56, I think 3.9 may be on the high side. I said, I think I'd recommend a biopsy. So he went to his urologist and he had a biopsy and they found prostate cancer. So he had the prostate cancer removed, surgery. And he had 2 brothers. First brother went for a PSA check after, this gentleman had prostate cancer found, and his PSA was elevated. So he had a biopsy and he found that he had cancer as well. And then the third brother also had a PSA check and his PSA was elevated. So he had a biopsy and he had cancer. So, pretty good evidence that it runs in families, right? So I want to talk a little bit about imaging of the prostate. So this has, changed a lot since I started out in medicine. Now we have, MRIs to take a look at the prostate. And so if this is straight out of our updated manual. It's called, the abbreviation we use is PIRADS for MRIs of the prostate. And if it's described as PIRADS 1 or PIRADS 2, from our standpoint, you could ignore that and rate from the other prostate tests that you may have available to you. If the PIRADS gets 3 or greater, then that might suggest you want to take a look at a later time after other studies have been done. So this is probably helpful just to keep in the back of your mind that this is in the manual. So if you see PIRADS and you're not sure what to do, refer to the manual or ask us for help if you ever need it. So I'm going to talk about prostate biopsies. And normally the prostate is about the size of a walnut or a generous sized truffle. Trying to hit little tiny prostate cancers in that size gland can be difficult at times. So it's kind of like a needle in a haystack sometimes, even when you're using an ultrasound to give you a hand. So I don't know if any of you know how prostate biopsies are done, but it's a one-handed, spring-loaded biopsy gun. And when you hit the button, it sounds like a gun going off. So, not exactly ideal, but this is the way it's done because the other hand is probably holding the ultrasound wand, because what you want to do is insert the ultrasound in the rectum and then ultrasound the prostate, and then with the other hand, stick the gun in to biopsy those sites and probably take as many as 12 cores if possible. And on the right side of this slide, you can kind of see what happens. You stick the gun in, it has a sharp edge. You go through, hopefully, the prostate cancer. The gun kind of collects a sample and then you pull the gun out. And some of the hazards are, well, first of all, the biopsy is kind of tiny. So you're working with very tiny biopsies and you're trying to hit any lesions that look abnormal, but you're trying to take cores from all around the prostate. So you get a pretty good surveillance of the whole gland. The trouble is you're going through the colon wall or rectal wall. So, there's bacteria in the rectum. So you're kind of sticking that needle through all those bacteria into the prostate, et cetera. So you can introduce bacteria, and actually, there are downside risks to prostate biopsy. So, as underwriters, we say, well, why can't they just get another biopsy? No big deal. Well, it is kind of unpleasant. There are people that actually can develop infections after the biopsy. They can get septic and require, IV antibiotics. So, you got to keep an eye on people. Often people are given an antibiotic after the biopsy is taken. If you travel on an airplane, you may see blood in the urine. It's common to see blood in the urine after the biopsy is done anyway, but even a week later, you might fly in an airplane and you may still see blood in the urine. That's just one of those things. And if the biopsy is positive, you actually have to let the site heal for 6 weeks before surgery can be done. So you can't just dive in there right away if you have a positive biopsy. It has to kind of, the prostate area has to heal up before you go in and do a radical prostatectomy. So here's kind of what I wanted to mention about how difficult it is to find prostate cancer sometimes. And that's because it can be in any shape. It can, look like any of these particular food items where if you were trying to hit the olive in the olive loaf, you might get it or you might not. So that's why prostate biopsies are difficult, even when you're using an ultrasound. And the prostate cancer may grow in sheets rather than in a nodule. So that's why it's hitting a tiny target sometimes is difficult to do. And here's what you get when you do the biopsy. That gun takes out a little thin slip of tissue like this, and that's all you get. So you have to make major decisions based on a tiny little biopsy. And some pathologists are better than others at reading these things. So in this particular case, the dark staining cells are prostate cancer. So you have to try to figure out just from this little biopsy what Gleason stage this particular person is in. And so it is a tough diagnosis to make. So they're difficult to interpret, these biopsies. Some pathologists are better than others. If you say you get 12 cores and one of them is 3 + 3 = 6, it may be that, but some other pathologists may read that as a Gleason 7, or maybe you just got an area that happened to be Gleason 6, but there are other areas that have Gleason 7, like a 3 + 4 or a 4 + 3. So it wouldn't be uncommon for somebody to be understaged or undergraded just from one biopsy core. So if you had 1 out of 12 positive, you're hoping you got the right answer, but maybe not. And what's available are second opinions from experts, and one of the best places in the country is the Johns Hopkins Prostate Pathology team. And you can send pathology slides, biopsies to them, or if the whole prostate is removed, you can send them all the slides. And they're expert in looking at prostate pathology and determining whether the cancer is present and what the Gleason grade might be. And this is a doctor joke. What do you call the doctor who graduated in or at the bottom of their pathology training program? You call them a pathologist, right? So we got the biopsy, we got the PSA. What are some of the other confirmatory testing that we might want to do, or some people do? We don't have this in the manual, but I wanted to share this with you because you may see it when you look at a case in the APS. There may be additional information. The second bullet is the PCA3 test. So I wanted to mention that. That's a urine-based test. and I'll mention when that's useful. And then there's also a prostate health index, PHI, that you may come in contact with. So when you get these slides, you can keep these on standby. So if you ever see any of these things, you can go back and look at it, and maybe it will help you, or you can always contact us. So I wanted to mention these additional tests that you may see, and sometimes I get confused, so I have to go back and review them. So I thought what I'd try to do today, because if I can't understand it, then it's not going to be very easy for me to explain it to you, right? So I have to kind of deconstruct and then reconstruct these things for myself, because I have kind of a simple mind and I need to understand like what exactly I'm working with here. So the PCA3 test is done in the urine. If it's a level greater than 35, and obviously none of us are going to remember that number, that's why you can keep these slides. And that's to help you determine, should we biopsy or not? So the PCA3 urine test, should I biopsy or not? So maybe that would help you make a decision if that's going to be useful. You may see something called a 4K score. And this is also to biopsy or not. And the number that's used is a greater than 7.5% probability of aggressive cancer. So that score will be delivered to you with the test result, and another time to keep this slide so you can refer back if you see a 4K score. What do I do with it? There's a third test that I put on here is the epi switch, which involves epigenetics. And I'm going to talk a little bit about that. And that's, is there a high or low probability of cancer? So it looks at it in a little bit different way. And then there's a test called the Decipher Genomic Classifier. And that is, what's the likelihood of metastasis in the next 5 years? And there's a score from 0 to 1. So each of these has different scoring patterns. And I'll just show you a little bit. In case you see them, you won't be completely baffled, hopefully. But as I said, I have to go and review these things again myself. So this PCA3 urinary biomarker, it has an increased specificity for prostate cancer compared with PSA testing, because we know PSA can be up in benign disease as well as cancer. And where PSA is a glycoprotein that may enter the bloodstream, PCA3 is a gene that exists in the nuclear material of prostate epithelial cells that may be shed into the urine. So that's the difference. It's a little bit different than what PSA is. And as I said on the prior slide, a score of 35 or higher is considered optimal for diagnosing prostate cancer, while a score lower than 25 may indicate more indolent disease. The 4K score is a follow-up blood test after an abnormal PSA and or digital rectal exam. And it's to help you assess the probability of finding aggressive cancer. And a score of 7.5 or higher may indicate the need for a biopsy. So if you see that, greater than 7.5%, it may be helpful. Hopefully the physicians that are using this, are on the same wavelength as these instructions, which I'm sharing with you. So it's what does the 4K stand for? So this is a word that's difficult for me to wrap my head around. A kallikrein, Kallikrein, is a protein biomarker, and the reason it's called 4K because there's 4 kallikreins. So the 4 kallikreins are total PSA, free PSA, intact PSA, and human kallikrein related peptidase 2. So there's 4 of these things, and this is where the score is derived, and it gets a little complex and when you start talking about kallikreins and what they are. But if you just remember that there's 4Ks, and that's why it's called the 4K score, and the score greater than 7.5 can be helpful. It's indicated for use in men 45 years of age and older who have an abnormal PSA or digital rectal exam prior to the first biopsy or after a negative biopsy. So it can be helpful to see how you should proceed in working up somebody that you're concerned may have prostate cancer. The third test I wanted to talk about is this epi switch. So it's an epigenetic test, and it's a combination of 5 epigenetic markers. So what is epigenetics anyway? That's a word we hear. It's confusing to me. So it's a study of how your behaviors and environment can cause changes that affect the way your genes work. So the way this test is reported, it's not a percentage reported to you. It's what you see in the right bottom. It's reported as high probability or low probability that there's a problem. So you'll see something like that reported maybe in the APS, or maybe somebody will just mention the words, that the epigenetic test, the epi switch, showed a high or low probability. Okay. The fourth test I wanted to mention, which you may have heard of before as well, is the Decipher Prostate Genomic Classifier. And this is used to determine how likely the patient's cancer is to metastasize within the next 5 years. So it's a score of 0 to 1, and it's basically looks at the activity of 22 genes in prostate cancer, prostate tumors. So another test that you may see in an APS, and you can see if the score is high or low between 0 and 1, to see if this is likely a more aggressive kind of prostate cancer. And here's what the report would look like. And the reason that you get 2 pages is one would be done on just a biopsy. That will say biopsy report, and the other one will say the RP report. That's after a radical prostatectomy. And you should get either a high, intermediate, or low score here to help you decide on how aggressive this particular tumor may be. So you might see a page like either of these. It's independent of the other information, so it's kind of like a standalone kind of a test. So it doesn't incorporate, other things like PSA or whatever. So it's just kind of an independent test based on these genes. And this would be the second page of the report, and it also gives you, is this a high or low risk kind of a situation that you're in? So if you see any pages that look like this that say Decipher, that's what they're talking about. So hopefully this helps a little bit if you see any of these when you're underwriting a prostate cancer case. So you got the PCA3 in the urine, greater than 35 to biopsy or not, the 4K score. The epi switch is high or low probability of cancer, and the Decipher genomic classifier. Okay, hope that helps. So in our manual, you'll be able to see the clinical TNM classification, tumor nodes and metastasis. And I included the clinical staging here. So a lot of times what you're going to see is the bottom bullet, which is T1C. And that means that when a biopsy was done, it showed prostate cancer. It doesn't mean that it's in situ or anything else. It's just that's how the prostate cancer was diagnosed. And then the other classifications are, what it's determined by how extensive is the cancer and the different lobes of the prostate. Often, it's T2, A, B, or C. depending on if the tumor involves one or more lobes. And then, we have more difficulty underwriting cases where the classification would be T3 with extracapsular extension or invading the seminal vesicles. And then, of course, a T4 invading other structures. Those are high risk, and we probably don't take those kind of cases. So how did this Gleason score come about anyway? So I put a picture of Dr. Gleason up at the top left. So he actually drew these original pictures himself that are coded in color at the bottom. And he decided that prostate cancer could be in one of 5 grades. So grade 1, 2, 3, 4, or 5. So why do we have a number plus another number? And so here's what the recommendation was when they first started doing Gleason grading. If you had either a biopsy or you had the whole prostate removed, you tried to look at the biopsy or the prostate that was removed, look at all the slides. And so how did you, let's say the whole prostate was removed, kind of like that honey baked ham up at the top. So fortunately, it's not around any holiday, so hopefully we're not eating honey baked ham today. But you basically want to take the prostate and slice it up just like a honey baked ham, make a slide out of each slice. Sorry. Then look at each slice under the microscope. And what you want to do is look for the most prominent of these 1 through 5 scores on each slide. So is it a Gleason 3? Is it a Gleason 4? Is it a Gleason 5? What's the most prominent looking area that you see? After you do that, then you go back and look at it again. And what's the second most prominent score? So that's how you get the 3 plus 3 or 3 plus whatever other number. Or so if you see a 4 plus 3 equals 7, that means that the most prominent score was 4, and then you had some 3 on the side. That risk is higher than a Gleason 3 plus 4, which showed mostly 3, but some 4 on the side. So if you had to pick what's the better mortality, you'd pick the 3 plus 4. Okay, and so that's how this all came about. And that's why the pictures at the bottom show you that the 5 at the bottom are pretty scary looking, crazy looking histology. So obviously the higher the number, the worse the mortality. And in our last AJCC edition of how to do cancer staging, these grading groups were added, and this is in our manual. And you can see that we have now grade group 1 through grade group 5. And so it kind of puts these Gleason scores into different grading groups, and that helps us with rating and mortality assessment. So often you're going to see a grade group 1, which is a 3 plus 3 score. Now there's actually some zealots, with the active surveillance, people are thinking that, Gleason scoring maybe a 3 plus 3 really isn't any big deal. We don't need to worry about it. Why operate or treat with radiation? We can just watch those things. And there's actually one of the advocates in Toronto, Dr. Klotz, he's saying that a 3 plus 3 equals 6 is not cancer. And I wouldn't necessarily agree with that. And I think even Johns Hopkins says that let's not call it not cancer, because, for years we've been using this and it's been helpful guide for us. So if you see a Gleason 3 plus 3 equals 6 and the doctor writes it's not cancer, you might want to take a second look at that and assess what's going on, because I think most eminent pathologists would still call this cancer. So just want to mention robotic surgery, which you may see in the APS. You may wonder, like, how is this actually done? Why are we using robots now? So all of these trocars are inserted into the abdomen and by the surgeon. And the surgeon actually sits in another room with a module. And actually, it's a very sophisticated operation where the doctor is actually operating from a separate room. Hopefully there's an anesthesiologist in the room with the patient. That would be good. And you actually inject CO2 into the abdomen to kind of blow it up like a balloon. And that gives you a lot of working space. And it also puts light pressure on all the little capillaries, venules, and whatever to prevent bleeding when any of those are cut. So the CO2 actually is kind of like a CPAP, continuous positive pressure, putting pressure on all the little whatever blood vessels so that you have less bleeding and less requirement for a blood transfusion. So that's always helpful. And then at the end of the surgery, they release most of the CO2, but you still may have kind of a pooch from some of the gas that's been injected into the abdomen. And the surgery is done using all these trocars, and you remove the gland through one of these incisions, and then they heal up so you have less, you don't have a big linear scar down your abdomen. So it's can be, in the right hands, it's a very effective tool for operating. And I think most people have gone to this now. There's other ways of treating prostate cancer, including, you may have heard of advertisements on TV of using CyberKnife or proton beam or external beam radiation. So we'd consider any of these as our radiation treatment. And basically what you want to do is kill all the bad cells without killing too many good cells or causing any burns from radiation. So the idea is blast the prostate cancer cells and don't destroy anything else that you need in the way of that particular area in your pelvis. There's also cryotherapy. We don't really have this in our manual, but you may see it occasionally. And that's actually like freezing the prostate cancer cells. We don't have as good a handle on, the effectiveness of this. So I'd be a little more cautious if this is being used, but just something to be aware of if you happen to see it in an APS. So what are red flags? If you see people that have been prescribed medication to interfere with testosterone, given after prostate cancer surgery or radiation, it may be because there's a failure. And so it may be, if you see a drug like I've highlighted in yellow here, like Casodex, what they're trying to do with this is to prevent the testosterone from helping prostate cancer cells grow. And so you want to kind of hormonally affect the area and prevent problems from prostate cancer, which you thought may have been treated effectively, but now there appears to be some kind of recurrence. So any of these drugs, if you saw them in an APS, would be a red flag that, oops, something's not working. And of course, if somebody has a super high alkaline phosphatase after prostate cancer, that might be a tip-off that there's bone involvement, that the prostate cancer has already gone to bone. So keep an eye on the alkaline phosphatase. In our guide, we have a prostate cancer staging, and this is how it looks. So you can be aware if you go to our manual after the talk. And so we have the T stage, the N stage, and M stage. Hopefully you don't have any nodes or metastasis. And then we have PSA levels. So you can kind of use those indicators along with the grade group that we talked about from Gleason and put it all together and come out with, okay, where does this person fall out and how we should stage their prostate cancer. So it takes a little getting used to. So you may want to, study it a little bit when you first get going with this section in our manual. But this should help you kind of get an idea of how the mortality ratings came about. And one thing to keep in mind is this particular slide, that it gives you additional information on how to proceed under certain circumstances. So if you get in a kind of you're not sure which way to turn, this should be helpful in giving you some assistance in which way to go on how to handle the particular tumor. So it's kind of intense here. We're not going to go through it line by line, but something to refer to if you have additional considerations, or they've had multiple treatment combinations, or they've had recurrence. You can look at this part of the manual under prostate cancer. Now, let's say somebody has been treated by any of the particular treatments like surgery. You need to follow these mandatory guidelines in order to come out with the rating that we've recommended. In other words, for surgery, you would want to make sure that the margins of the tumor when it was removed are clear, and the tumor didn't extend through the margin of the radical prostatectomy. That would be bad. Also, the PSA after effective radical prostatectomy should be undetectable. So it should be reported as less than 0.1 nanograms per milliliter after a certain time period. So if you see a PSA that is greater than that after surgery, that's a problem. For radiation, you have to follow these 3 bullet guidelines. So for each of these treatments, make sure that after whichever treatment was done, that the case meets these mandatory follow-ups. Then for active surveillance, there's a whole litany of things that need to be done. So PSA should be done at least every 6 months. PSA is increasing. Do this. There should be no clinical progression of disease. And then it tells you how often repeat biopsies are necessary. And, the applicant may or may not agree to getting, repeat biopsies. So active surveillance, there's a lot required. It's not quite as easy as just deciding, we'll just follow this and see how things go. You have to follow it in these particular ways in order to meet the criteria to get the ratings that we're recommending. And then at the very bottom, it says if follow-up is not consistent with the above, RNA, otherwise rate as below. And so you kind of have to follow all these particular guidelines in order to get the ratings. So if you see the word biochemical failure, it just means the PSA is going up, and you probably want to refer that to a medical director. This is how the ratings are structured. I apologize, I can't share the ratings, but as Lisa mentioned, since some of the people who are attending today may not have access to our manual, we're not allowed to share the ratings. If you're disappointed, you can write me a nasty letter, that's okay. But I'm not allowed to share them today, but you can just go into our manual and see what they are. But I wanted to show you how this is structured. So we have an age differential, age less than 60 or age 60 plus for the different stages. And then we have it broken down into surgery, radiation, or active surveillance. And, there's some very favorable ratings for like a stage 1. So, I think Dr. Rigotti did a fantastic job when he reviewed all the SEER data to come up with these ratings for us. So I have a case for you. I have a 52-year-old hedge fund trader with a PSA of 8.9, and he's diagnosed with Gleason 8 prostate cancer. So he had a T1C staging because he had biopsy showed prostate cancer, Gleason 8. We'll just assume it's 4+4. So his urologist advises definitive care, but the applicant prefers active surveillance. So he says, well, I guess I'll follow all those guidelines you told me that I have to do. And he does get a PSA repeated after 6 months, which we said is recommended. And its PSA is 8.5 nanograms per milliliter. So like, just think in your own mind, we're not going to talk about any specific rating, but think of, what would you possibly do and how would you consider this, quote, active surveillance? So, first of all, hedge fund traders usually like to take risks, right? I mean, that's what they do for their living, is they hedge funds, and they want to make big killings in the stock market by either trading short or long. So, this person probably is used to dealing with risk. Unfortunately, probably not a good idea to be risking yourself when you have a diagnosed Gleason 8 prostate cancer. So I would say, just in my own mind, you may or may not agree that probably not a great case to be put into an active surveillance. So, I'd have a lot of qualms about this particular situation myself. So I don't know if you agree or not, but you can ask questions at the end here and see what you think. So I have a second case. So this is a 75-year-old male executive with an increasing PSA. He had a recent PSA of 6.5. So, for a 75-year-old male, that's not a huge deal, but he did have a prostate biopsy, even though we said, that the preventative services people don't think, he should necessarily have had one, but he had, one of 12 cores was Gleason 3 + 3 = 6. So he and his urologist have decided on active surveillance, but to cover his risk, he's an executive. He figures, well, I think I'll go with active surveillance. I'm 75, but he now wants to apply for 10 million of life insurance and thinks that he should deserve a standard rating because that Gleason 3 + 3 = 6 is on the, reasonably low side. So, just think a minute, like, what would you do? So, it wouldn't be unreasonable to think that, if that one core was really a Gleason 3 + 3 = 6, that, he's on the low side of risk, and that if he followed up with all the active surveillance monitoring, that, that might be okay. But he's basically transferring his risk to you. And, you're on the hook for the face amount. So, even though people may meet certain standard guidelines, they still have a reason to want to get life insurance. And, you don't want to be the one necessarily holding the bag when things don't go well. So always something to consider when you have tough cases like this. Is that core really a Gleason 3 + 3 = 6? Were there any other features that you might be concerned about? So a lot to think about, and that's why we're here to help, and always willing to lend a hand if you ever have questions. Third case, so 41-year-old male has a family history of prostate cancer in his father. and 2 uncles, brothers of his father, ages 57 and 58. His mother died of ovarian cancer at age 62. He had a PSA of 0.8 nanogram per milliliter a year ago, and his PSA last month was 2.7, but his urologist treated him for possible prostatitis with Cipro. His PSA, his doctor advised another PSA in 6 months. So, you'll have to think about, could we accept him for life insurance now with the rating? So in your mind, like when you put all this stuff together with the family history, including that his mother died of ovarian cancer, like what did she have? Does she have a genetic issue? His PSA kind of zoomed up there. So we call that velocity, how fast it went up. So, there are a lot of adverse features in this. So you'd have to think about, what would you do in a situation like that? It seems like there's some risk here. And I think this is the last case. 67-year-old male had an elevated PSA of 11 and had a biopsy that showed Gleason 4 + 3 = 7. So he had a radical prostatectomy 5 years ago, and there was noted there was a slight extension through the prostatic capsule. So additional periprostatic tissues were removed. So the prostate has a capsule. So say you think of like a cantaloupe, say there's kind of like a capsule around the cantaloupe. So in this particular case, the cancer kind of went through, the cantaloupe. So his immediate post-op PSA and at 6 months was undetectable, essentially. A recent PSA was 0.7 nanograms per milliliter, and his urologist put him on Casodex. So I just wanted to highlight the point that when you see that PSA rise after a radical prostatectomy, and you see a drug like Casodex, that's like waving red flags that he's got a biochemical failure. And, you probably want to be very cautious about cases like that. So what are my takeaways from today? So the best cases that we're going to see are usually stages T1 and T2, and the lower Gleason grades, like a 3 + 3 = 6. Hopefully that was a correct pathology reading. In general, radical prostatectomy surgery is better than radiation and is better than active surveillance, although in certain situations, we may give the same rating in the manual. And then you got to observe all those mandatory follow-ups. So you got to read the small print for each treatment modality that we may, the applicant may have undergone. So you have to check for surgery, do they meet everything? For radiation, do they meet everything? And for active surveillance, are all those requirements being met? So any questions? As I said, we're here to assist you on any difficult cases, and you can always ask us for help if you have any particular questions on prostate cancer. I hope it's been a little bit of an update for you, but any questions? I'm happy to see if I can lend a hand.
All right, Dr. J, we do have a few questions out in the Q&A box. The first one is, if an older gentleman has BPH and he's on Flomax, would you be concerned about undiagnosed prostate cancer or suggest obtaining medical records?
Yeah, there's a lot of men have BPH. Flomax doesn't decrease the PSA in half like finasteride, those kind of drugs. So it may help with problems. It depends on the case. It's kind of case specific. A lot of times with BPH, what actually you worry about is hopefully they don't have anything like urinary retention. And that can be a problem, or they can get urinary sepsis called urosepsis. So hopefully the BPH is not getting out of hand where there's actually trouble actually urinating. Working up for prostate cancer, it's probably on the low end of risk. So unless there was some other particular feature that you were concerned about, that may not be something that's a red flag waving at you, and you may be able to proceed on the case without doing a major investigation of that. So if the PSA was in the normal ranges for that particular person, maybe you wouldn't need to go digging too deep for any additional information.
Great, thanks. All right, the next question is, can the PSA go up after a prostate biopsy? And when is the best time to check the PSA post-biopsy?
Yes, PSA could go up because you're kind of mucking around in the prostate. So, those cells are going to release PSA. So the PSA can go up. It can go up from things like riding a bicycle. If you sit on like a narrow bicycle seat, definitely up after a prostate exam. So there's a lot of reasons that PSA can go up. So that's why you want to get the blood drawn before you get the prostate biopsy, before you get the digital rectal exam, and before you go on a 30-mile bicycle ride or things like that. So yeah, you want to get the blood drawn when the prostate has not been disturbed, and that'll give you a more accurate level.
Okay, on a related note, there's another question. What about PSA at exactly 0.01 after a radical prostatectomy?
Yeah, that would be good. 0.01 would be great to have after a radical prostatectomy. It basically means undetectable. Just to give you an idea, we're talking about nanograms per milliliter. That's 1/1000th of a gram. So you can imagine that the difference between, say, 0.01 and 0.05 or something like that is so tiny that most labs have difficulty actually categorizing it. Exam one, I believe, one of their 28 or 30 labs out in California actually can do super duper fine discrimination on how low the amount could possibly be. So I think they have one or two labs that can do that. But most labs are just going to kind of give you the old less than 0.01 or less than 0.1 or whatever the case may be as their, we can't find it, so it's probably not here.
Thanks. All right. Another question is there a difference between a prostate MRI and an MP MRI? Or are we talking about basically the same thing?
I think I had that on that slide. I can't answer that right off the top of my head, but I think on my slide, if you get a copy of my slides, I think I mentioned that. So that's probably something I need to learn more about. Sorry, I can't answer that one now, but I'll be happy to look it up and then send everybody an answer.
Okay. And there's another couple questions here. The next one is, the prevalence of prostate MRIs have increased significantly in recent years. I've noticed many are PIRADS 4, but the only recommendation is to have a repeat MRI annually. And if no change, then no biopsy is recommended. How do you approach these from an underwriting stance? Do you make an offer, postpone?
Yeah, well, as I said in our guide, if it's 3 or greater, we have more concern about that. I'm on the conservative side with prostate cancers. In other words, if I think that there's something that might be fishy or abnormal, I'm more concerned about it. I'm not in the quote active surveillance camp. So I would think that you'd want to be very cautious about extending yourself if you're not sure exactly what you're dealing with. As I said, people don't want to get rebiopsied. It's a real pain, not just a difficult thing to get it all scheduled and done. But I'd be a little more concerned about the higher PIRADS, that there's something maybe going on, and it's I think it would be better to know rather than not know what's going on. So I would lean more in that direction of maybe I'd want to get more information on that case before I proceed. I'm not necessarily willing to just take a flyer and say, well, if they just want to watch it, that's okay with me. So is that okay to, hopefully that answers the question?
Okay. We have one last question in the box. Another one just came in. This one is age a major factor in considering prostate cancer risk?
Yeah, sure. As the older you get, the much more likely you are. So definitely age is a factor. So although the PSA levels are going to go up, that could be benign disease, but as your age goes up, you're more likely to have prostate cancer. Hopefully it's not affecting people's lives, but definitely in younger people, if you do have prostate cancer, you have a much more longer period of time which you would like to live. So you want to be much more cautious about things. People that are in their 70s and 80s and 90s are much more likely to have prostate cancer than younger people.
Okay, one other one just popped in, a little bit of a case question. Oh, so this is an older age male over the age of 75. He has a Gleason score of 6, 3 plus 3, PSA of 6, and under surveillance. He had a CT scan of his body that was negative for metastases. 1 year after the biopsy, he had a minor PSA elevation. The question is, what are the chances this client could die of prostate cancer? And what are the concerns for older males over the age of 75 with low levels of cancer, such as the Gleason 6?
Yeah, so a lot of people are just going to watch this with active surveillance, and this person may do great over time period. He made it already to age 75, and I think you said 75.
Mm-hmm.
So it's definitely would fall into our active surveillance. You'd want to get all the studies as recommended at the specific time intervals, but he would appear to be at a lower risk standpoint based on what you've shared information-wise. So even a slight increase in PSA may not be that impactful, but you need to follow those guidelines for our ratings, as I outlined them under the active surveillance part of the manual. Does that help?
I think so. And then we've got some thank yous on here saying it was an excellent talk, greatly appreciated. And we have cleared the questions. So
well, if anybody comes up with any others, we're more than happy to send you answers best I can put together. Also, if you have any other suggestions for future talks or even future things that we can look at in the manual, let us know. We're here to help you and do whatever we can to make life a little easier, hopefully, and try to provide the best service we can. So we'll look forward to seeing you at either at AHU or some future meeting. Come up and say hello to all of us that'll be there from Optimum or any other meeting that we're attending. So thanks for your attendance today. Really appreciate it.
yes, again, thank you, everyone. And please, when you get the survey, we appreciate if you take a moment to fill that out. So thanks again and enjoy the rest of your day.